We'll be breaking down all major concepts covered on the exam. I
Right.
mean, imagine a young patient rolling into the ER and they are in such severe agonizing pain that they're actively vomiting. They can't sit still, they're writhing on the stretcher.
Oh, yeah, the classic kidney stone presentation.
Exactly. Yet their only actual injury is this microscopic crystal the size of a grain of rice just tearing through their ureter. So today, we're dissecting the presentations that bring patients to the hospital in absolute crisis. I'm Harvey.
And I'm Donna. We are MCCQE reviewers, and we're here to help you feel incredibly comfortable and, confident with your exam review process.
Right, because we want to move you beyond just rote memorization. We're getting into the underlying pathophysiology of acute renal and urinary diseases so that the answers on exam day just, well, they feel intuitive.
Absolutely. And to make sure we're bringing you the absolute best information, today's deep dive teaches directly from reliable StatPearls articles.
We're covering some seriously high-yield topics today: acute kidney injury, nephrolithiasis, and urethritis.
But before we jump into the mechanisms, we do need a quick mandatory disclaimer. This deep dive is for medical education only. It is not medical advice, and clinical decisions should always involve a qualified healthcare provider.
So let's start right at the top of the urinary system with acute kidney injury, or AKI.
Right. And, in the past, this was broadly called acute renal failure. But AKI is the specific term used now to describe a sudden and often reversible reduction in kidney function.
And for the MCCQE, just relying on a sort of vague conceptual definition isn't enough. You actually must have the strict KDIGO criteria memorized.
Yes, KDIGO, the Kidney Disease Improving Global Outcomes Framework.
Right.
So AKI is officially present if you see any of three specific parameters. First, a serum creatinine increase of 0.3 milligrams per deciliter within 48 hours.
Okay, 0.3 within 48 hours.
Exactly. Second, a creatinine increase to greater than 1.5 times the patient's baseline within 7 days.
Got it. And the third one?
Third is a urine volume of less than 0.5 milliliters per kilogram per hour for 6 hours.
I really want to highlight that third criterion for you, the drop in urine output. Because clinically, serum creatinine is a major lagging indicator.
Oh, absolutely. It takes time to build up.
Right. When a kidney takes a hit, the filtration pressure drops immediately, so urine output drops almost instantly. But it takes time for all that unfiltered creatinine to actually accumulate in the bloodstream.
Which means if you're only watching the morning blood work, you might completely miss the first crucial hours of an AKI.
Exactly. Which is why closely monitoring urine output on the wards is so critical. So once you identify that an AKI is happening, your immediate task is to figure out the etiology.
And we categorize the causes using the classic three-bucket framework, right? Pre-renal, intrarenal, and postrenal.
Yeah, let's visualize this. Think of the kidney as a highly sensitive water filtration plant.
Okay, I like that.
So the pre-renal bucket is a severe drought, or like a clamped inflow pipe outside the facility.
Right, the actual filtration machinery inside the plant, the glomerulus and the tubules, is perfectly fine.
Exactly. The issue is that they simply lack the hydrostatic pressure to push fluid through. It's just systemic hypoperfusion.
You see this in massive hemorrhage, severe dehydration, heart failure, or even a localized plumbing issue like renal artery stenosis.
And the key takeaway there is that the cellular architecture is totally intact. The kidney is just reacting appropriately to a lack of blood flow by holding on to sodium and water, trying to preserve intravascular volume.
Which perfectly brings us to the second bucket, intrarenal or intrinsic AKI.
Right. So in our filtration plant analogy, the blood is arriving just fine, but the machinery inside the plant is completely broken.
Yeah. This involves direct damage to the renal parenchyma, most commonly acute tubular necrosis, or ATN, and acute interstitial nephritis, AIM.
Because, the proximal tubule and the thick ascending limb of the loop of Henle are just highly metabolically active.
They require massive amounts of ATP to run their ion pumps. So if a prerenal state of low blood flow goes on for too long, those cells literally suffocate.
It's wild. They die, they detach from the basement membrane and just slough off into the tubular lumen.
And that transforms a simple, fixable prerenal hypoperfusion state into intrinsic acute tubular necrosis.
And the same intrarenal damage happens with nephrotoxins. Like if a patient is taking massive doses of NSAIDs over the counter, that can trigger an allergic inflammatory response in the kidney tissue.
Right, leading to acute interstitial nephritis.
Which brings us to the third bucket, postrenal AKI. In our plant analogy, the water is filtered, but the exit pipe is just welded shut.
The physiology here is completely driven by back pressure. If there's an obstruction downstream, like benign prostatic hypertrophy clamping down on the urethra, or a pelvic tumor, or a kidney stone, the urine just backs up.
And that hydrostatic pressure builds all the way up into Bowman's capsule, neutralizing the forward driving pressure of glomerular filtration.
But differentiating these three buckets clinically, that is where you earn your points on the MCCQE.
Seriously, I mean, in medical school, we spend hours learning how to calculate the fractional excretion of sodium, the FANA, to figure out if an AKI is prerenal or intrinsic.
Oh, the classic FENA.
Right. We're taught that a FeNA under 1% means prerenal because the intact kidney is reabsorbing sodium to hold on to water. But on exam vignettes and, well, in the ICU, almost every patient with heart failure or cirrhosis is already on a loop diuretic.
Yep.
Don't diuretics just completely ruin the FeNA calculation?
They absolutely do, and it's a major exam trap. Loop diuretics literally force the kidneys to excrete sodium.
Right.
So if you calculate a FeNA on a hypovolemic patient who just took furosemide, the fractional excretion of sodium will artificially look high. It'll be over 2%.
Making you falsely believe they have intrinsic tubular damage when they're actually just severely prerenal?
Exactly. So in those cases, you calculate the fractional excretion of urea instead, because urea reabsorption isn't significantly affected by diuretics.
But really, the absolute most reliable, real-world clinical test to prove a patient has prerenal AKI is simply giving them volume.
The fluid challenge, assuming there's no clinical contraindication, like acute pulmonary edema, you just administer intravenous fluids and watch the urine output.
Right. If the GFR improves rapidly, the kidney just needed volume. It was prerenal.
But if you give fluids and the creatinine just keeps climbing and urine output stays flat, the tubular cells are likely dead. You're dealing with acute tubular necrosis, and renal function is going to take weeks to months to recover while those cells regenerate.
And the urine microscopy will give you massive clues here. When those dead tubular cells slew off an ATN, they clump together with TAM horsefall proteins in the tubules.
And under the microscope, these look like muddy brown casts.
Yes. If you see the phrase muddy brown casts on the exam, you just lock in ATN.
Similarly, if the microscopy shows white blood cell casts, or if the vignette describes sterile pyuria, meaning white blood cells in the urine, but bacterial cultures are negative, you should heavily suspect acute interstitial nephritis.
Because the white cells are there because of an allergic inflammatory reaction, right? Not an infection.
Exactly. Now, identifying the cause is vital, but managing the complications of AKI is what actually saves the patient's life.
Because the kidneys have stopped filtering, so metabolic products just build up. And the most lethal of these is potassium.
Hyperkalemia is a medical emergency that is heavily tested. Potassium dictates the resting membrane potential of cardiac myocytes.
So when serum potassium climbs dangerously high, the resting potential moves closer to the threshold for depolarization.
The heart muscle becomes incredibly irritable, which leads to peak T waves, widened QRS complexes, and eventually lethal ventricular fibrillation.
The management algorithm here is a multi-step process, and you have to know that the order really matters. Your very first move is intravenous calcium, usually calcium gluconate.
And notice that calcium does absolutely nothing to lower the amount of potassium in the blood.
Right. It doesn't fix the potassium.
Not at all. Its sole purpose is to restore the gap between the resting membrane potential and the threshold potential. It stabilizes the myocardium to just buy you time.
Which is so crucial. Once the heart is safe, then you actually have to move the potassium out of the bloodstream. You do this by pushing it into the cells.
We administer insulin, which drives potassium intracellularly, by stimulating the sodium-potassium ATPase pump.
But since insulin will aggressively drop the patient's blood sugar, you obviously always give it with intravenous glucose.
Right. You can also use beta agonists like albuterol to help shift potassium into the cells.
And finally, to permanently remove the potassium from the body, you use gastrointestinal potassium binding agents, or if the kidneys are still producing some urine, loop diuretics.
But sometimes medical management just fails, and the potassium keeps rising. That's when you have to initiate renal replacement therapy or dialysis.
The indications for urgent dialysis in an AKI patient are non-negotiable. You pull the trigger for severe non-responsive hyperkalemia, uremic pericarditis, or severe fluid overload leading to pulmonary edema that just ignores high-dose IV diuretics.
We really cannot overstate the gravity of acute kidney injury. I mean, it complicates up to 7% of all hospital admission.
Yeah.
And the in-hospital mortality rate for AKI sits between 40 and 50%. For patients requiring ICU admission, mortality jumps to over 50%.
That staggering mortality rate often comes down to missed downstream issues. And, well, one of the most undeniable, agonizing causes of postrenal AKI in younger patients is a physical blockage in the ureter.
Yes.
Let's move down from the microscopic cellular damage of the kidney into the macroscopic mechanical trauma of nephrolithiasis, kidney stones.
Kidney stones affect roughly 12% of the global population. They form when solutes in the urine become supersaturated and basically precipitate into solid crystals.
And on the MCCQE, matching the specific stone type to its histopathology and underlying cause is pretty much a guaranteed question.
Oh, 100%. So we have 4 main types you need to memorize.
Right.
About 80% of all stones are calcium stones.
Primarily calcium oxalate or calcium phosphate.
Right.